Good morning, dear audience. Thank you for joining me on my 6-month progress report of my PhD journey entitled The Application of Enhanced Recovery After Surgery Protocol to Improve Patient Outcomes After Surgeries. Allow me to introduce myself. I am András Czébely-Lénárt. I'm a fourth-year medical doctor at Semmelweis University Obstetrics and Gynecology Department and a first-year PhD student at Center for Translational Medicine, under the guidance of Ferenc Bánhidi and Balázs Lindner, along with our scientific methodology supervisor Jakub Poferica, and with our precise statisticians Mikolt Bakony and Péter Fehérvári. Our vision is that every patient will get the best evidence-based care before and after surgeries, and that makes our mission to emphasize leaving old methods behind based on enhanced recovery after surgery recommendations. Currently, we have two ongoing projects. The first is investigating the necessity of mechanical bowel preparation in bowel resection surgeries, and the second project is finding the proper timing for after bowel resection surgeries for the first feeding. So, our first project is investigating the patient outcomes in bowel resection surgeries with and without mechanical bowel preparation. This is a systematic review and meta-analysis, which we started in last year's September. Mechanical bowel preparation is an unpleasant procedure before surgeries, wherein fecal matter is expelled from the bowel lumen by drinking large amount of special types of laxatives. Nowadays, this procedure continues to be widely used, even if it should be excluded based on ERAS protocol. ERAS is an up-to-date evidence-based approach to major surgeries to improve patients' recovery. Based on our key articles, we can see that with or without mechanical bowel preparation, the anastomosis leakage and the surgical site infections incidence is almost the same, with an odds ratio of 0.90 and 0.99 respectively, and the length of stay at the hospital could even be reduced if we leave out the mechanical bowel preparation method. So our aim is to investigate the efficacy of mechanical bowel preparation based on postoperative complication rates, such as surgical site infection and anastomosis leakage, and the length of stay at the hospital. That arises our clinical question. How does the presence of mechanical bowel preparation affect postoperative complication rates in patients undergoing bowel resection surgeries? We use the PICO framework. We are focusing on surgeries with bowel resection, whether the patient had or didn't have mechanical bowel preparation. And we are measuring postoperative complication rates, such as surgical site infection and anastomosis leakage, and length of stay at the hospital as key outcomes. Our hypothesis suggests that excluding mechanical bowel preparation from preoperative routines will reduce the postoperative complication rates in surgeries with bowel resection. We conducted our systematic search in 3 different databases. We used this search key with 2 domains. First part is for the preparation itself, and the second is the surgeries we are focusing on. It resulted in 17,000 results, and we ended up with 114 eligible studies with my selection pair, Loretta Nyíradi. We already finished all the data analysis of the RCTs we found, so we have some preliminary data based on these articles, and we have still ongoing analysis of observational studies results and the subgroup analysis of oral antibiotic preparation and resection site-specific complication rates of the surgeries. Here you can see my first figure. This is the pooled proportion of surgical site infection with or without mechanical bowel preparation. The mechanical bowel preparation group has 4,884 patients, and the control group, so without the mechanical bowel preparation, we have 7,111 patients. The final odds ratio is 1.03, which means the left side represents the incidence without bowel preparation, and the right side is with bowel preparation, the surgical site infection incidence. And we can see the odds ratio is 1.03 with quite a high value of P. So that means there is no significant difference between the two groups. The heterogeneity of the patients are quite moderate heterogeneity, but it is because of the widespread of the types of the surgeries and the types of the illness, why was the surgery was performed. The second figure is the pooled proportion of anastomosis leakage with or without mechanical bowel preparation. And as we can see, we had a bit higher odds ratio, which suggests that maybe if we use the mechanical bowel preparation before surgeries, we may end up with slightly higher anastomosis leakage rate, which is the most feared complication after such surgeries. So our strengths of this study that we included real-life studies, not just RCTs. We are measuring a novel outcome as the length of stay in the hospital. And we have subgroups for resection sites of the surgeries and oral antibiotic preparation combined with mechanical oral preparation. Our limitation that we are not comparing oral antibiotic preparation alone, and we have quite heterogeneous patient population. Our preliminary conclusions is that leaving mechanical bowel preparation doesn't increase complication rates, and we can implicate this for practice by to reduce the patient's burden, improve postoperative outcomes, and we are trying to break the old dogmas with up-to-date evidence. The implications for research is that we may need further researches for gynecologic oncology surgeries or endometriosis surgeries, and we may have to examine complication rates specific for resection site. In this project, we almost finished with data extraction, and as we mentioned, we have some preliminary results. My second project title is comparing the safety and efficacy between fasting and early oral feeding after bowel resection surgeries. This is also a systematic review and meta-analysis, which we started in last year's November. Conventional protocols after bowel resection surgeries recommend fasting, administrating only intravenous fluid until full bowel function recovery. However, the mentioned ERAS protocol suggests early oral feeding, as it could reduce the length of postoperative ileus and length of stay at the hospital. As we can see, the resolution of the ileus and length of stay at the hospital could be shortened if we use the early feeding method after bowel resection surgeries. So our aim is to investigate the advantages of early postoperative feeding, oral feeding. Our clinical question is that does early oral feeding have more advantages than fasting after bowel resection surgeries? We use the PICO framework here as well with bowel resection patients after operations, and we are examining when they had the first oral feeding after these surgeries, and we are measuring the length of the ileus and length of the stay at the hospital as primary outcomes and postoperative complication rates as secondary outcomes. Our hypothesis suggests that early oral feeding after bowel resection surgeries could reduce the length of postoperative ileus, length of stay, and even complication rates. Our clinical implication is to ensure quicker and safer recovery after bowel resection surgeries. For summary, our first project, we want to finish it by this year's May, and the second project by this year's summer. And for last but not least, a smooth sea doesn't make a skilled sailor for this PhD journey. So thank you for your attention.
Thank you very much, András. Any comments or questions from the audience, please?
So I can see you can't find any difference between the infection rates. And what do you think that can it be clinically relevant? Do you plan to change some protocols or not?
Thank you for your question. Well, so we wanted to. So our hypothesis was that leaving the preparation method doesn't higher the incidence of these complications rates. So these numbers support our hypothesis. So we wanted to prove that there are no significant differences.
Congratulations, András, to your great presentation. My question is regarding to your first project. You said in the strength that real-life studies are included as well, not only RCTs. So my question is there any contraindication that was not investigated regarding the RCTs? So in the RCTs were only patients included without this contraindication. Are there any differences between the real-life studies and the RCTs?
Well, I think they are more close to real life, so they are not very controlled studies, all these observational studies. Maybe we can widen the database opposite to previous meta-analyses if we include observational studies as well, if I understand the question right.
My question is the same, nearly the same question. Do you expect different outcomes from the real-life studies if we are comparing the RCTs and the real-life studies? So more significant outcomes.
Thank you for your question. We want to find out, but if we examine them, that we may have stronger evidence opposite to the previous meta-analyses. So maybe it will provide stronger evidence to leave this preparation method.
I have a question regarding your second topic, because I also investigated fasting time in preoperative patients. And in Brazil, for example, there are big times of fasting before surgery, also if the surgery is rescheduled. But I'm interested in what is the reality here in Hungary in your clinic. What do you see? Are they adhering to the ERAS protocol more, or do they have very old protocol that they are leaving the patient fasting for 10 hours or something?
No, I think that we are contributing to the ERAS protocol. We trying to be as much up to date as possible.
Great, thank you.
At our clinic.
Are you planning to differentiate between rectal surgery and upper part of the bowel surgery? Because yes. I think there will be a difference.
Thank you for your question. Yes, as I mentioned, for the strength and the ongoing analysis that we have, sorry, I can't find it, but we have subgroups for resection site-specific outcomes. But the eligible studies, few of them just publish resection site-specific outcomes. But if we find one, then we include them as well, of course. Yes, thank you.